So the class is brachial plexus. In this there are three competencies. One competency is formation of the brachial plexus, its branches. Another competency is variations in the formation of brachial plexus. And the third competency is clinical features of Head's palsy and Trump's palsy or Trump's paralysis. Coming to formation, it is formed by spinal roots, that is C5 to T1. This brachial plexus gives nerve supply to upper limb. It extends, that is, brachial plexus extends from lower part of neck into axilla. It contains 5 parts, and they are roots, trunks, divisions, cords, and nerves. Coming to roots, the roots are C5, C6, C7, C8, and T1. So these are the roots. Coming to trunks formation, the C5 and C6 join to form the upper trunk. Then C7 alone forms the middle trunk. C8 and T1 join to form the lower trunk. So thus trunks are formed. Then after trunks, they divide. Trunks divide. So they divide into anterior and posterior divisions. So you can see the anterior and posterior divisions. So that is the posterior division and the anterior division. So divisions again will join to form cords. So anterior division of upper trunk, anterior division of the middle trunk join to form the lateral cord. Then the anterior division of lower trunk alone forms the medial cord. So we have completed anterior divisions. Then we go to posterior divisions. So posterior division of upper trunk, posterior division of middle trunk, and also posterior division of lower trunk join to form the posterior cord. So thus cords are formed from the divisions, that is anterior division and posterior division. Then we go to branches. So coming to branches of the lateral cord, there are 3 branches: median nerve, lateral root, musculocutaneous nerve, and lateral pectoral nerve. So these are the branches of lateral cord. Medial cord branches. Medial cord branches are 5. Again, the median nerve, medial root, medial pectoral nerve, ulnar nerve, medial cutaneous nerve of arm, medial cutaneous nerve of forearm. So these are 5 branches of medial cord. Then posterior cord. Posterior cord also gives 5 branches: radial nerve, axillary nerve, upper subscapular nerve, lower subscapular nerve, and thoracodorsal nerve. So these are the 5 branches arising from posterior cord. Apart from cords, there are branches coming from roots also. So roots give dorsoscapular and long thoracic nerve of bell. 2 branches arise from roots. Then we go to branches arising from trunks. That is the upper trunk. The upper trunk gives rise to nerve to subclavius and nerve to suprascapular nerve. So we have seen the formation of brachial plexus and the branches. Then we proceed to next competency, that is variations in the formation of brachial plexus. So the coming to cause of variation, It can be due to abnormal development of trunks, divisions, and cords. So during development of nerves, that is axonal development, they are guided by or regulated by chemoattractants and repulsants. Any alterations in the signals of these attractants or repulsants can lead to variation in the brachial plexus. There is one condition called pre and post fixed plexus. These constitute about 25%. Among which, the prefixed is the most commonest. In prefixed condition, the C4 contribution is significant. In post-fixed, the T2 contribution is more. So in this, both the conditions, there is a longitudinal shift of the plexus, and this can result in changes in the supply of the sensory and motor distribution. Then we come to variation at the level of trunks. Upper trunk is formed by C6 and C5 and C6, and the trunk or all the trunks usually pass through interscalene groove. So you are seeing one triangle that is called as scalene triangle. So that is the scalene groove. And anteriorly you can see one muscle, that is the scalenus anterior muscle. And posteriorly you can see one more muscle, that is scalenus medius. And the base of the triangle is formed by the first rib. So this is the scalene triangle and the scalene groove through which the upper trunk passes. But sometimes the scalenus anterior pierces the scalenus anterior. Sometimes the upper trunk can pierce the scalenus anterior or pass in front of it. And there is another variation. Phrenic nerve can arise from brachial plexus. Then we come to variation at the level of divisions. These are more common in the antidivisions of middle trunk. So the variation is the antidivision may join the medial cord. Then variation can also be at the level of cords. There are multiple variations at this level. T1 may fail to contribute to posterior cord, or the posterior cord is not formed at all. And after the formation of brachial plexus, there is one certain relationship between the cords of the axillary artery. You can see in the figure that axillary artery is in the center, and medial to that is the medial cord, lateral to that is lateral cord, and posterior to artery is the posterior cord. So this occurs, that is in the second part of axillary artery. Then variations at the level of axilla. The axillary artery usually arises from 7th intersegmental artery. If the artery arises other than from 7th, that is from 6th, 8th or 9th intersegmental artery, then the relation between the axillary artery and the cords is altered. Then we come to another competency, that is clinical features of Erb's palsy and Klumpke's paralysis. Erb's palsy is caused due to injury to upper trunk of brachial plexus. The most commonest cause is difficult childbirth. In adults, it is rare, and it is caused due to injury in between the shoulder and the head. In both the cases, injury occurred, that is C5 and C6, and these roots are violently stretched and cause injury to the roots. Erb's palsy. In Erb's palsy, the upper limb limps from the shoulder. This is mostly due to injury to biceps muscle. The nerves that are injured in the Erb's palsy are suprascapular nerve, musculocutaneous nerve, and the axillary nerve. Coming to suprascapular nerve, this nerve arises from upper front. It supplies supraspinatus and infraspinatus. These muscles are lateral rotators of the joint. So, in injury or in the Erb's palsy, the arm is medially rotated. Musculocutaneous nerve. This nerve innervates muscles, that is biceps and brachialis. These muscles help to flex elbow, and also biceps is a powerful supinator. Because of injury to these muscles, the arm is extended at the elbow and also pronated. Axillary nerve. This nerve supplies deltoid and teres feather muscles. Deltoid is a powerful abductor of shoulder joint. As a result of nerve lesion or Erb's palsy, the arm is adducted. So there is one posture in Erb's palsy, and the characteristic posture or the position of arm in Erb's palsy is the arm is adducted and medially rotated at the shoulder joint. The arm is extended and pronated at the elbow joint. This position is often described as a weighted hip receiving hand. So we next come to trunkus palsy. This is due to injury to lower trunk of the plexus. Injury is due to hyperabduction traction injury of the arm. It is again caused during childbirth, or it can be caused due to a lung tumor compressing the T8 and T1 spinal roots, and also cervical sympathetic ganglia. In trunkus palsy, that is the C8 and T1 which are affected, they supply the intrinsic muscles of hand. This injury can result in claw head. In addition, there is also Horner syndrome, that is because of involvement of cervical sympathetic chain. Horner syndrome includes ptosis, that is drooping of upper eyelid, anhidrosis, that is lack of sweating, and miosis, that is constituted. Thank you.